Dear colleagues, my name is Maximilian Merz. I'm an attending physician and responsible for the myeloma and CAR-T program at the University Hospital in Leipzig, Germany. And today I would like to talk a few sentences about sequencing BCMA and anti-GPRC5D bispecific antibodies in patients with myeloma who relapsed after 3 lines of therapy. So recently, actually, Professor Usmani from the New York Sloan Kettering Center wrote an article called Embarrassment of Riches because we have now 3 different bispecific antibodies approved for the treatment of triple-class exposed relapsed refractory multiple myeloma. 2 of them are directed against BCMA, namely elranatamab and teclistamab, and 1 is against GPRC5D, namely talquetamab. So at the moment, it's really challenging to say which one is supposed to be the first one, which is the second one, was the optimal sequencing. And I think to answer that question, first of all, we have to look at the response rates for these bispecific antibodies. And there we see basically at the moment no significant differences when we look at the trials that led to the approval. So most of them range around the 70% overall response rate, and about 30% of patients go into CR or better after treatment, or that's the best response. So based on the response rates, we cannot delineate the 3 agents from each other. Secondly, we have to look at the side effects, of course. And I think here there's the major difference between BCMA and GPRC5D. While anti-BCMA treatment is connected to high rates of infection, especially bacterial and viral infections, we really have to pay close attention to antibiotic, antiviral, and also antifungal prophylaxis. And of course, when it comes to immunoglobulin substitution, we have to be very strict about immunoglobulins. So if your IgG level, polyclonal IgG level, is below 4 grams per liter, we always have to substitute IVIGs. And there's the first difference. If you have a patient who's in general already very prone to infectious complications or had infectious complications in the past, my first choice would be the GPRC5D antibody, because I do not want to aggravate the risk of infection with another BCMA treatment. And when it comes to GPRC5D, of course, 2 side effects have become very prevalent. One of them is the exfoliating disease of the skin of the palm and also the feet. So sometimes when you start the GPRC5D directed treatment, for example, talquetamab, you recognize an exfoliation of the skin, especially in your hands and your feet. So if you have a patient who is, for example, I had a guitar player or a person who enjoyed playing the guitar at home as recreational activity, I think it's not the best idea to use that drug, because that might impair the quality of life significantly for that kind of individual. And the second most important side effect is the loss of taste, so dysgeusia. Some of the patients, even after the ramp-up dose, we usually use 4 ramp-up doses in talquetamab. They have a complete loss of taste within the 3rd or 4th dose of the drug. So again, if you, for example, have a patient who is a professional cook or enjoys cooking, or just tells you that food and wine and stuff like that is very, very important for the patient, then I think your first choice should be an anti-BCMA treatment, because talquetamab or GPRC5D directed therapies in general can impair these functions very significantly, and there, of course, impair also the quality of life. And the third most important point, I think, at the moment is that we have to play a little bit of 3D chess. So if you think at the moment what you should use, BCMA or GPRC5D, you actually should already think about your next line of treatment after the patient will fail that specific line. Because at the moment, of course, we are also at hands of 2 different BCMA-directed CAR-T cells, FDA and also EMA approved. So at the moment, I would prefer actually starting talquetamab or any kind of GPRC5D directed treatment, because you have BCMA directed CAR-T cells as another salvage option if GPRC5D fails. So if you have a patient who might become eligible for CAR T in the future, I think it would be very smart to start with the GPRC5D directed treatment, and then if the patient relapses, go to GPRC5D or BCMA directed CAR T cells. The other way around, if you use BCMA first and then BCMA CAR T treatment, it has become prevalent that actually a lot of patients who do not respond to GPRC5D lose the GPRC5D antigen, but the same is true for BCMA. So BCMA can be lost forever, actually, due to biallelic loss of BCMA locus on chromosome 16. So if you want to re-expose the patient to a BCMA-directed treatment, I think it's always very important to check if the antigen is still present. So to make it a bottom line, look at the side effects. If you have a patient who is at risk for severe infections, go to GPRC5D-directed bispecifics. That's also the truth when you have a patient who is might be a candidate in the future for CAR T cells, then I would prefer bispecifics against GPRC5D, because then you can change the antigen. But if you have a patient who is still active with his hands or her hands, has an occupation that needs fine motor skills with manual activities, or is very involved in food, enjoying wine, or even be a professional cook, then I think GPRC5D would be the second choice, because BCMA does not affect these functions.